Thank you all for coming. The meeting for the Commission's Finance and Planning Committee will come to order, and the Secretary will call the roll.
Sure, I'll start with you, Commissioner Chow.
Present.
And Commissioner DeLeo.
Present.
Thank you. I will read the landing on. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, or the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, or forgotten their responsibility as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the April 2nd, 2024 meeting.
Good. So the minutes before us, is there a motion for acceptance?
I move accept.
And a second, is there any public?
Is there anyone in the room who'd like to make public comment? Just for my edification, is everyone here to present? No? Okay, all right. Okay, wonderful. So there's no public comment and there's no public comment, so all in favor?
Aye.
Great, thank you so much. The minutes are approved. We can move on to item 3, the monthly conference.
Good. Thank you, Mr. Bennett.
Oh, and actually, let's just note, this is Mr. Goodwin's last meeting. I believe he's retiring between now and the next meeting, or at least he won't be actively working, so.
It's my last meeting.
Maybe should roll.
Yeah, I'm returning into June. I'll be here a bit longer, but I'll be out of town for the June meeting, visiting my family, so.
Well,
My last
have a
one.
great.
Thank you.
retirement.
Congratulations on your retirement.
Thank you, I appreciate that. Thank you. Okay, we have 8 items on the monthly report this month. The first one is from UCSF, Ward 86. This is an HIV health services contract. Requested action is approval of a contract amendment with the Regents of the University of California, San Francisco, Ward 86, to increase the total contract amount with contingency from $2,065,671 to an amount of $7,836,602, which reflects an increase of $5,770,931. The current contract term is for 1 year, July 1, 2023 through June 30th of 2024. This amendment will reflect a new term extending to 6/30 of 2028 for a total of 5 years, increasing by 4 years. 1 year term on the current contract. The Health Commission previously approved this contract just recently on February 6th, 2024. The annual amount without contingency is decreasing from $1,844,349 to $1,755,322, representing a reduction of $89,027. This represents one-time grant funding added to the fiscal year 23-24 term in the amount of $33,225. These were Riding Right Part B funds, as well as $55,802. These were Riding Right Part E, ETHE, or Ending the HIV Epidemic Grant funds, to extend the grant terms a few more months until June 30th of 2024 to align with the general fund fiscal year that will begin again on July 1st, 2024. I hope that answers your questions about the one-time reductions of funding. If you have other program questions, we have Beth Neary, the Assistant Director of HIV Health Services, available to respond.
Any questions?
No, just.
We had just, as you said, recently approved it, so want now to add to the 4 years to the contract. Why did we not actually start? I mean, this is a very important
Service.
service.
Yeah, the services were previously in MOUs, interdepartmental MOUs with Ward 86. Last year was the first year we transitioned it to a UCSF contract. We utilized the Administrative Code 2142 to do a 1-year contract with plans of doing a solicitation in that year to do a fuller contract term after that. In the interim, the board has approved the government-to-government contracting, which will allow us to directly contract with UCSF and other counties without requiring solicitations. So I believe that might have had some impact on moving forward with that in these 4 years now, but I'll defer to Beth Neary in case there's other information to add to help answer.
That is exactly right. We did a 1 year 2142 because we thought we needed to RFP it. And, oh, sorry, and that no longer was necessary. And since some of these services are very specific to things.
We can't hear you.
You can't hear me? I'm sorry. Can I just agree with Dean? If you can't hear me?
Able to.
Can anybody hear me?
Log
Let me,
off and log back on.
apologize.
Two. Great. In the meantime, if the commissioners is okay, if we move on to the next contract. Sure.
Okay. And number 2 is a Luna Health contract with Community Health Equity and Promotion. Requested action approval of a contract amendment with Luna Health to increase the total contract not to exceed, or NTE, with contingency from $9,697,459 to a new not to exceed total of $11,003,885, representing an increase of $1,306,426. The contract term will remain the same. This contract provides program administration and support services to the Community Health Equity and Promotion section in the following areas of CHEP hepatitis C prevention services and CHEP ending the HIV epidemic services. The prior annual amount without contingency was $1,060,936, and it's increasing by $147,807 to $1,208,743. If you have any program questions, we should have Nicole Trainer, who is the Budget, Contract, and Communications Manager for CHEP, available to respond.
Commissioner.
Yeah, I just had a question about who the subcontractors are that for this program and how they're chosen.
Nicole, are you available to?
Yes, I am.
Subcontractors are how they're chosen.
Yes, I couldn't hear the question. You said subcontractors on,
What's going on today?
can you guys hear me?
Seems like it's something.
We did get a response from Nicole on that, but that was forwarded to Mark.
Right, it's in your commissioners come here and try to use paper with the responses that you will receive, but still it's relevant. That's really
I think that the response was not on my question.
About the subcontractors?
Yes.
can you guys hear me?
So I'm gonna put my cell phone in the chat, and Nicole, if you can call it and then talk into it, I'll put it on the microphone in the house to deal with it right now.
Or I can hear. Okay.
We could try to play charades. It's my last 98 years.
Hopefully this works. Do you mind calling that and then I'll put it up to the speaker, then we'll see.
Your call has been forwarded to voicemail. The person you're trying to reach is not available.
What she's doing, I think, just to have my own follow-up, it's a long-standing contract, and so I was just wondering if subcontractors have been the same all the
You're trying to reach is not available. At the
whether there's sort of competitive process choosing them.
There is, and there's a, responded to the process, described it really well about how they were involved, limited involvement as they should be, through the subcontracting process, but.
Okay, can you hear me now?
Yes.
How is this coming up? Can you hear it okay? Okay, great.
Okay.
So, the question regarding the subcontractors in Spain for the green program. One of the programs for the Hep C is only funding FTE. So there's no subcontractors on the funding. For our core HIV prevention grant, those particular subcontractors will be made the same on previous HIV grant cycle.
So I was just wondering that, I mean, it's good that there's consistency, but how are they,
Selection process.
yeah, how are they assessed and
Nicole, could you some,
the process to sort of make sure that,
how did that done?
yeah.
Thank you, Commissioner.
How were they assessed, all the subcontractors?
Selection.
And monitor the quarterly basis. Their subcontractor agreements, and additional payments as well as the basis are not paid. Subcontractors have the ability to show that they'll deliver for certain achieved.
And that's done by Helena.
Yeah, and Nicole, I'm sorry, could you also describe the selection process and what Jeff's oversight and role in that is? That was part of the initial
Yes, and
as well.
first, please complete the thought around, does the Luna do the evaluation and then the selection process, the subcontractors?
Yes, collaborating with the subject matter expert with the program manager within CHEP, and also with the health coordinating staff. In addition, for the subcontractors that are elected, they follow the same process that the city is required to follow. In some cases, RNG, some of the services such as, for example, our global contingency program that goes through a solicitation process, and there are some funding within those within this particular grant. I'm sorry, that went through an RFQ.
Thanks.
Thanks.
Could you also explain, there's some feedback, okay. When we first did the contract, and you subsequently had additional monies added into the program, so were these not available for the original contract? And now we're adding these because they became available? I'm just wondering why we didn't have them in the original contract.
We're extending the term of this contract through one of the programs extending to June 30th of 2025. So this is our new HRG score grant, ES 240047. It's a new cycle.
Okay, so these were not available at the time we looked at the original contract.
Sounds like it was new grant funding.
Right, the grant funding comes in, and then we now find that we would have Luna administer that, and it's for the programs that they were already taking care of, so we've added that in. Is that what we're talking about?
I believe so. Is that correct, Nicole?
Yeah, these are programs that they have already been providing program administration for. That's correct.
Okay, very good. Okay,
Thank you for being nimble and doing this all thing.
thank you. You want to find out?
Thanks, Mark.
It's Nicole.
And if we go back, Ms. Neary wrote on the chat to me saying that Mr. Goodwin covered the response to the previous question, and all she was going to do was agree and expand that tiny bit, but that basically he responded, and there's not any new information.
Okay. Is that said? We'll then move on to the next contract.
Okay. The third contract is CDC in the amount of $85,632 and a decrease in a previous work order funding transfer of $47,522. We received some questions from this contract item yesterday. One was about the contract term, which has been corrected in the updated monthly report that you have a copy of. And then there were also questions about how clients are selected for these services and how does their work on Hep C implement or add to the services from the Haluna Health contract we were looking at earlier. We had a response from Nicole Trainer that we received by email that I provided to Mark that you should have there. I can summarize for you. I have in my notes as well if you like.
We need that verbally summarized, Commissioner, or do you have that?
Basically, Nicole expanded that the current subcontractors are with Glide and San Francisco AIDS Foundation. They're tasked with implementing community-based Hep C community navigation services, aimed to expand Hep C testing and treatment for eligible clients in collaboration with the END Hep C project coordinator and END Hep C strategic director. SFAF and Glide recruit both current and new clients to undergo training as trained in Hep C navigators, ensuring that services effectively reach the community members throughout all the neighborhoods of San Francisco. And then the second part of that question, Nicole also added that the ending Hep C epidemic is a statewide initiative necessitating strategic planning and collaborations among city partners and county jurisdictions. The Hep C work outlined in the contract aligns directly with the funding and efforts delineated in other Haluna Health programs in the report that we referenced earlier. The funding allocated in the Haluna Health contract, CDC and state Hep C specific funding supports 2 Hep C data management staff dedicated to citywide Hep C data management, analysis, and reporting. And the data is instrumental in assessing the outcomes of collaborative Hep C endeavors across the city, pinpointing Hep C health disparities among various populations, and informing both current and future Hep C initiatives. That was in relation to the contract about coordination with Haluna.
I think my confusion was because in the, or not, just the need for clarification was with the Health Foundation contract description was quite a narrative about how closely they work with subcontractors and how they were chosen and how the health department was involved in that, but with the Haluna Health one, there wasn't there. And so it's just, again, the inconsistency with how things are described in the contracts just sort of begs the questions, I guess. Especially when they're doing the same work.
Similar work, yeah. Okay, thank you, Commissioner.
And in follow-up, Commissioner Andrew-Yarmouth's question, since both of these are dealing with Hep C, what is the difference, or why do we have several agencies doing similar type work? Or maybe it's not similar and it's not clear what the differentiation is.
Good question, Commissioner Chow. Nicole, are you able to respond to that?
Can you hear me?
Yeah.
The market. Okay.
They changed this,
It's not working. Sorry.
Okay.
Here we go. It's critical, the contract that to not have C work. However, it's just being different. They're in the Public Health Foundation. That's what Hep C navigation specific program for treatment and in addition to testing, where the health contract, those 2 funding amounts are to fund the data manager. So those folks are not in the field services. They're actually analyzing the data to drive Hep C efforts, so not just for that Hep C navigator program itself, but there's several different Hep C consortia within the city. And so a lot of that surveillance data is filtered into these 2 particular data managers who manage the program at the program level. And we also want to be addressing these Hep C disparities citywide, so that data is also analyzed by the data managers. So one is program implementation services that are subcontracted to our data.
I see. So, and it's that the data program were separate and therefore, Illinois Health was found to be best to do that. Meanwhile, programs are being done over at the foundation, for, this, FC initiative. Is that why they're separate, or just wondering why maybe one agency wasn't doing all of it?
Something foundation doesn't necessarily have an intimidating to for staffing. So in that public health foundation contract, there's no contracted human resource program administration or supplement health within their solicitation. It's specifically in their scope of work is for human resource program administration, which is why staff are added to that contract. There's no staff added to the foundation contract. Those are one of the two distinct differences between those two contracts.
Okay, that's helpful. And I was happy to hear that also the Hep C has the Hep B component, which, well, certainly some of us are very much needing to have this as a important initiative. So understand, Illinois Health does administration much better. They won the contract for that, whereas here the foundation is creating the programs. So thank you very much. Okay, you can go on.
Thank you, Nicole. All right, next item, number 4, is with San Francisco Study Center. This contract is through the Office of Health Equity. Requested action is approval of a contract amendment to the San Francisco Study Center, increasing the total contract amount contingency from $579,688 to a new total of $1,656,102, representing an increase of $1,076,414. The current contract term of July 1, 2022 through 6/30/2026 for 4 years will remain the same. This contract provides program administrative support services to address racism in healthcare settings. This includes the management of subcontractors that will implement work related to the health equity, learning improvement and recommendations. The annual amount without contingency is changing from a current amount of $308,737 to a new amount of $1,195,691, an increase of $886,954 due to an increase in a PEI grant funding of $86,954 and a one-time increase in CDC grant funding of $800,000. We received questions regarding this contract yesterday, and there was a response to these from Tracy Burris from the Office of Health Equity, which I can summarize for you. She's saying that the Laguna Honda Department of Education and Training provided required regulatory, didactic, and competency-based education, including mandatory in-service, new employee orientation, and other clinical and non-clinical required trainings. The contract with the San Francisco Study Center will support the Department of Equity and Culture, or DEC, to research, develop, implement, and test new models for ongoing experiential learning and reinforcement that support sustained cultural change for equity, belonging, and safety. These new models may include innovative pilot micro-trainings using adult learning theory, problem-based scenarios, errorless learning, bystander intervention practice, and interventions designed to support learners to interrupt bias, racism, and disrespect. They will include small tests of change, evaluation, and recommendation for implementation, including strategies for sustainability. These models, once tested and evaluated, may be further developed and integrated into day-to-day practices. This one-time funding was awarded to Laguna Honda, to LHH, under the leadership of the previous Office of Health Equity Director. If you have any other questions, we have Tony Rucker, the DPH manager and ADA coordinator, as well as Tracy Burris, who's the interim chief health equity officer from the Office of Health Equity, available to respond to your questions.
Commissioners, any questions?
Yeah, so the department's Office of Health Equity subcontract or contracts with the study center, who then subcontracts with others to do the work. Is there a direct, interaction for exchange learnings, knowledge, and so on with the subcontractors and the Office of Health Equity, or does everything go through the study center.
Yes.
The findings as well as, sort of assessing the performance and the.
Evaluation,
Yeah,
other
evaluation.
their goals and objectives. So we have Tony or Tracy
Yes.
available.
Tony, could you try to speak and see how it works?
Absolutely. Yes. Good afternoon, commissioners. This is Tony Rucker. I'm working in operations in the Office of Health Equity, and this is the contract that we have with the Study Center, and they do have subcontractors. Those subcontractors are selected through an RFQ process that is community opened, and it's a solicitation that goes to the entire Bay Area community. And those solicitations, that's where the CBOs are selected. These are the subs of the Study Center contract. The way we have set this up, commissioners, is that the Study Center is the contractor, and we meet with them on a weekly basis. So we meet with the Study Center and the selected CBOs. We have health program coordinators who work directly to oversee the actual work that's going on through the subcontractors. So they have weekly meetings, and then we have weekly report-ins through the Study Center where we summarize, and we have planning, collaborative planning and fiscal reporting of how they're spending their funding, making sure that it's lining up with their goals and objectives. And we have the monthly financial reporting that we do with the Study Center to make sure that the subcontractors have the resources and the supports from the Study Center doing that program administration. So there's a sequence of weekly meetings that we have that we set up on a cadence where we just oversight, we just watch and provide oversight and guidance to the Study Center, who's actually doing the management of those CBOs. And so we have that data reporting that comes from the fiscal side, as well as the programmatic outcomes. What are the goals and objectives that these CBOs are in the community providing the work? Those goals are constantly before them with the metrics that they're capturing and the data that they're capturing, qualitative and quantitative, from the community.
Thank you. So is the necessitation of the study center as sort of the intermediary because there isn't that competency within the Office of Health Equity or the human resource available? Or is it because there is a particular expertise within the study center to do that type of management, feeding that sort of back to the office and then forward to the subcontractors and then executing into the community?
Absolutely. It's primarily based on the latter, where they have that expertise. This Study Center has a long history of providing that direct engagement with the community in a way that they have that history of also having that bi-directional arm back to the department. And that gives us the authenticity to have a partner with the face, but they know that we're there alongside that partner to provide that bi-directional support for the community through the Study Center back to DPH. So it's that kind of engagement that's building the trust and the authenticity that we are developing as a department, more so around these small PDSA kind of projects for community.
And would you say then that I mean, that is a preferred way for the office to work? That, I mean, is there an alternative that you would like to see, or is that really the preferred way?
I think it's an opportunity for us and the Office of Health Equity. We're looking at this because of the amount of intensive time and engagement that the Study Center is putting into this. So we're gauging, like, how could we do more? And so what level of time and staffing? So we're measuring that in terms of what does it actually take to do that kind of deep embedded kind of support for that kind of work for us. So currently we have the Study Center being able to do more of that, and we're gauging and kind of measuring how do we take on more of that and what would it look like from an FTE budgeting kind of framework to do that ourselves. It's kind of a PDSA for us as well to see what would that look like so that we can have some really strategic planning on the programmatic side and fiscal side to do more of that in-house. What would that actually take?
Okay, thank you.
Absolutely.
I don't have any further questions, so let's go on to the next.
Great, thank you. Okay, contract number 5 is another Helena Health contract with PhD, the Center for Public Research. Requested action is approval of a contract amendment on the Saluna Health contract to increase the total contract amount with contingency from the current amount of $2,435,590 to reflect a new amount of $4,243,334, representing an increase of $1,807,744. The contract term remains the same. The annual amount of $11,012 is changing to $443,812, an increase of $432,000. Responding to the question submitted yesterday regarding the large increase in the percentage of funding appearing to be incorrect, it is actually correct. It's just that the current amount on the contract at $11,000 is so small in regard to the new funding being added. The contract began in fiscal year 2021 with grants from the CDC, the Centers for Disease Control, and NIH, the National Institute on Health. Prior to this amendment, the earlier CDC funding in this contract had ended, and the annual NIH grant of $11,012 was the only funding remaining on this contract until this new amendment, which is adding the new funding of $432,812, is a result of funding being added from CDC for peer-to-peer detailing of $172,800 annually, as well as academic detailing program administration representing $260,000 annually. If you have any programmatic questions, we have Emily Raganold from the Overdose Prevention Quality and Contracts Manager from the Office of Overdose Prevention and Population Behavioral Health.
And we now have sound.
Now we have sound. Any questions for Emily?
So I had a contract term question and then a programmatic question. So in the reason for funding change, the additional funding from the CDC goes through fiscal 28. Is that correct? But the contract only goes through to 25. So the additional monies that aren't provided for this particular contract will be brought to us for approval in the future?
Second, I'm flipping to that. On my copy of the report, I'm sorry. Correct. The current term is not being extended, so if the funding continues, we'll bring this back for an amendment where it may need to go to a new contract. Emily, could you respond to if the new CDC funds for the detailing go to fiscal year 2028? And do you know if there's a plan to extend this contract or relocate to another contract after the fiscal year 25?
Yeah, so the CDC Overdose Stated Action Funds will continue into fiscal year 28. My understanding is that the Haluna contract will be extended if allowable, or it may have to be re-RFP'd.
So that money will just be on hold until either one of those actually occurs?
Yeah, so we have a
Correct.
year to figure that out. Yeah. Thank you, Emily.
Okay. And then the programmatic question I had was the Substance Use Research Unit for the California Intervention in Academic Detailing for Opioids Programs. What is that?
Yeah, so we have the local Center for Substance Use and Health that is run by Dr. Philip Coffin, that is part of the San Francisco Department of Public Health, which is operating the academic detailing program. However, they work closely and work under the California, I'm trying to find the acronym, the California Intervention and Academic Detailing for Opioids Programs, which is what informs how we implement it here locally.
And so Haluna Health just acts as the sort of pass-through
Correct.
this? And so do they have responsibility for the performance of the contractor? Is that either us or the California Department of Health, Public Health?
We locally have, we oversee the performance of this contract.
Okay, so so again, just a question about what the role of Haluna Health is. Do they have an expertise in this area, or is it strictly because of their management capabilities?
Strictly because of their management capabilities.
Okay. So, and that we don't have that competence in the department here, and we need Haluna Health to do that.
It's more of a bandwidth and competence issue, Emily.
Okay, so it's, okay, so resources.
Yeah.
Okay. I'm sorry to use the word competence. It's just the only thing that comes to mind, and
You know what you meant.
yeah,
The
but
sub- the
it's
subject
encompassing a
matter
number of things.
expertise,
Yeah.
Yeah.
Okay.
We have that, of course, but it's just a matter of having to find community partners to help with the heavy lift of.
It's just
these-
Haluna Health seems to have a lot of contracts that do that in a many different areas. And so just wondering whether there's a specific programmatic competence that they have over others, or is it because they really do have a high capacity for sort of management and administration of contracts on behalf of the department?
I think the latter, and especially in regard to the HR management and administration of the contractor staff that's often hired to help with the deliverables and oversight.
And would, if the department was able to um, manage hiring or bringing on additional staff, would that mitigate the need for a subcontractor like Haluna Health? Or is it really the kind of thing we just don't want to have to do within the department and use the resources that we have to?
Really good question. I don't know if I'm qualified to really answer that, to be honest. I would imagine that would be a great goal overall, like just the reality and the timing of getting there are impediments at times to getting to that preferred reality that I think we would all like to see, but it's just hard to make that happen, to be honest.
And
Above my bandwidth.
oh, and if I can jump in, it might be something to take to the full commission and in discussions with Director Colfax, because that might be a meta goal at some point. It's difficult for our staff at our level to know, but because consultants are used so much in the DPH to assist with staff who have expertise in that field.
Okay, thank you. I was just thinking, Dean, since you're leaving, you might have an opinion or some, some,
Free moment.
yeah,
Got it.
think insight that we might be able to sort of
A worthwhile.
ingest. Yeah, digest. Yeah, thank you. Okay.
I'm still trying to understand how we have, a prior annual amount of a contract that was about 2.5 million for 5 years, and it says the prior annual amount is only 11,000.
It tracked a few different grants. There was CDC funding, both from the federal and state level, and the NIH funding on the grant to begin with, and the original CDC funding that came from the feds and the state. That term ended. So the last couple of years, there's only been that 11,000 annual contract amount from the National Institute of Health that's been on that contract. And Emily was able to add her funding in regard to the priorities of the overdose prevention section to this contract because of the scope of work.
Well, did we then spend the 2.4 million?
I don't know, but I could check with the contract.
I mean, it seems very strange. Either we've been putting out the money instead of the grants in order to have this. I mean, the training program, we understand, is very good and important, but just trying to understand, what do we do with the 2.5 if we ended up with only 11,000 last month? Last year.
Yeah, good question, Commissioner. I was given the paperwork that had all the background of the expenditures of the allocations, but not the expenditures. So I'll follow up with the contracting staff to see what was spent from the CDC funding that has expired and send that to Mark and get that to you.
Okay, because somehow this, I mean, it doesn't all add up, right? I mean,
Right.
if we got 2.5 million for the 5 years and now we're going to 4.2, we've added about, roughly $2 million. But then if we're saying the annual amounts in the prior contract is only 11,000, I think I'm missing something.
Well, that's the annual amount, but the total contract amount with contingency was 2.4 million. with only 11,000 annually remain as.
What remaining is different from saying what we really spent the prior year.
Correct.
Do you think it's possible to get that clarification before like 5 o'clock? So when they vote, I'll at least be able to pass that on. If it's possible, please do. If not, then just let me know.
Okay, I'll reach out.
Okay, yeah, because we want to know, I mean, annually what we spent of the prior year, not what is left in the grant at the moment. Not what is left under the contract at the moment. Okay,
Okay, I'll
let's,
try to get that before 5 or
we'll
5.
then move on to our next contract.
Okay, contract number 6. Thank you, Emily. This is the Health Right 360 contract for the Soma Rise program. Total contract not to exceed our NTE amount with contingency remains at $9,875,729, with the current contract term of July 1, 2021 through June 30th of 2023 being extended to add a new term of 7/1/2021 through 6/30/2025 for a new total term of 4 years, extending the term for an additional 2 years. The prior annual amount without contingency will be reduced from $4,720,321 to a proposed annual amount without contingency of $3,811,853, representing a decrease of $908,468 annually. This is due to the elimination of funding for services previously allocated for the Tenderloin Linkage Center at 1178 Market Street, which were part of this contract. Capturing those savings from these eliminated services previously funded with this contract provides for an extension of this contract for 2 years without requiring an increase to the total contract NTE amount. We had received some questions yesterday. In response to these questions, the question asked, it was in regard to the objectives from the monitoring report that were summarized in the in an attached document you received earlier. What are the objectives? The monitoring report of January 2023 for fiscal year 21-22 does not show program deliverables. What has been the service experience for 22-23 and how many clients were served? So BOCC is currently in the process of monitoring this program for fiscal year 22-23. I just got this today from Jerna Reyes, the director of the Business Office of Contract Compliance. The report should be completed soon, pending additional data from the agency. The numbers gathered so far are 1,615 unduplicated clients and 7,195 encounters for the units of service. The program also has successfully implemented a client satisfaction survey for fiscal year 22-23 with a return rate of 85% and with 91% of respondents feeling welcomed and safe about returning to services. No performance objectives were created for this program's first full year of operation. I do want to point out, and this is something that Michelle was out sick, but still monitoring emails a bit, asked me to point out that BOCC is currently in the process of reevaluating the process for reviewing new programs, including this one, which may be creating a measurement to evaluate the ongoing processes and goals in the startup period of new programs until patterns of deliverables are established and appropriate performance objectives are finalized. Dr. Pading responded today and provided a little bit more context regarding the objectives outlined in the Mental Health San Francisco legislation. The Mental Health San Francisco legislation does not include specific performance objectives. The pilot program was designed to address these issues identified by the 2019 methamphetamine task force. That's according to Dr. Pading. And the number of clients shown, as I stated, represents a 1,615 clients served so far in 22-23, or served in 22-23. And if you have any other questions, Dr. Pading should be attending virtually and can respond by more detail. Dr. Pading, is there anything you'd like to add? Did I summarize that appropriately?
He's unfortunately not here.
Here he is.
He's in the room. Oh, there we go.
Thank you.
Hello, Commissioners.
Thank you.
Oh, geez.
Hey, Commissioner Chow.
How are you? Okay. Are you speaking to clarify the way this was written, which said that the goals were contained in the Mental Health San Francisco program? Or you're saying that we're going to be developing these goals out of working with the agency?
So this was developed initially as a pilot, and we, under the Mental Health Services, Mental Health San Francisco, it was to again conform with the recommendations of the Methamphetamine Task Force in 2019. This, we implemented this as part of the oversight of the work group, the MHSF work group, and we did a pilot report to that in October. During that period, we found that this program met and exceeded our goals, which we had 3 goals for the operational pilot, which are in addition to, or actually were done outside of the BOCC compliance performance. So we evaluated it as a separate quality project. The goals were, is it low threshold and welcoming? So where people were coming in off the street? Methamphetamine Task Force said many people were in crisis from drugs. So we wanted to ask the second question, was it able to accept clients who were in crisis or needing crisis-like services? And then the last question was whether this low threshold program could link people to services. So during the evaluation of this program, which again, the goal of the Sobering Center was to get people who are intoxicated and experiencing crisis related to drugs to come on in to sober up or to come down from drugs, and then to try to introduce them to services. So we found again that of the 1,600 clients, when we addressed them, 91% of clients said they would come back, 91% of clients said they were treated with dignity, and about 90 found it welcoming. So on that basis, we've had very good client satisfaction with good follow through. The second thing is we started to look at, are we addressing the crisis in the city that we're seeing on the streets? To this, we look towards our partners at fire department and the EMS services. This has become the #1 destination for the street outreach teams from fire department and to night, and they are dropping off anywhere from 1 to 3, on average, probably about 2 clients a night in these kind of witching hours where other services are closed. So we reserve beds just for fire, and you know that. So we're meeting that need, and we've gotten very good sponsorship from our other partners. And then the last thing is linkage to services. We are now evaluating linkage to services. We're currently undergoing a pilot where people are starting buprenorphine on the street with this co-tenderloin project, bringing them into the program, and then trying to link them back to services for the next stay. This is a 23-hour program, so within 23 hours, it's hard to do everything. Fortunately, however, we get many bites at the apple. About 20% of our clients come 6 or more times, and this is a group we've identified as we really want to see if we can, engage them and connect them. The first time when people come in, it's usually they want to sleep. Don't bother me, I need to sleep. And then they come in again and we give them some food. And then a third and a fourth time, we've been approaching them and they've been willing to engage. And we're looking to study the engagement and improve that as the next phase of the pilot. These are outside of the BOCC goals, which are more about units of service. They're actually oriented towards our treatment programs, like do you do your discharge summaries in a timely way? And we're trying to figure out how to modify the compliance goals. But right now, we're looking at this as a quality and improvement and a pilot project.
Yeah.
Well, I thought that was an excellent.
Yeah, I mean, it really does, to me, it's a qualitative improvement, I think, in terms of being able to describe, how we are approaching, the sort of harm reduction goals in San Francisco that don't necessarily lend themselves to this sort of more quantitative monitoring that is essential, but doesn't capture, the sort of the essence of what we're trying to achieve here. And that is, I think, sort of some of the dilemma that we face and that we question, often, as a commission, that can we match the BOCC requirements with what's really happening and what's, sort of, as you said, sort of more qualitative aspects.
Yeah.
I mean, eventually we will, but I think because this is a startup, it's like you don't really know necessarily up front what you're going to try to monitor or quantify.
Yes.
And I think that that's really important for folks to understand that that is the nature of startups, particularly this type of program and with this population. So I really appreciate that description of what you're trying to do and why it doesn't lend itself to BOCC processes at this point in time anyway. Yeah.
Well, it just seems to me that Dr. Pading is as valuable as he is because he did sit on the commission for several years and knew what we're looking for and actually has gone into the department and has done it. And so that's the type of information I think that we would all like to hear, that this is happening and that it's not just purely a BOCC question of the number of encounters, but what did we really do to the people? And a brief description like that is really helpful for us to actually enthusiastically, I would think, recommend the continuation of Soma Rise, which we had heard was very good. But I think the approach that you have put in place, that the department has, along with the supervision that you've been given to the Soma Rise program, I think is a very good example of what we really are looking for.
No, we're looking to serve. One of the things that I'd like to leave you with, we had a very implementing a Epic health system in a shelter setting. This is basically a drop-in shelter respite program. You come in, you get respite, and then things happen. We connect you, right? So engaging them in Epic was a big challenge because people coming in, they're intoxicated. They didn't really, at times, want to be interviewed. But the staff has done a really good job with giving them health screenings, getting them registered in Epic, and that made us eligible to be able to reclaim funds under CalAIM. So although we're asking for the budget extension, we've been able to maybe recoup about a quarter at this point, we think, maybe even more of our funds through CalAIM for basically a general funded program. And we look to do some more enrollment activities here because we think this is an unmissed opportunity to, reclaim Medi-Cal dollars. So
very good.
About the bottom line.
Look forward to hearing more about how this is progressing and how it might lend itself to the monitoring process that we have, or how the monitoring process will change based on what you're finding.
Thank you very much.
You made their day, Dr. Pading. Their faces lit up in ways they don't normally, so thank you.
We'll go on to our next contract.
Next item, the 7th contract is with Lion Martin Community Health Services. This is a primary care contract. This is a retroactive approval of a contract with Lion Martin Community Health Services for provision of primary care services for a term of January 1, 2024 to December 31st, 2027 for a total contract amount of $6,495,631, which includes $695,960 in contingency. The proposed annual amount without contingency will be $1,600,000. The contract provides primary care services at 1735 Mission Street in San Francisco. There were delays in receiving contract documents and coordinating approval by the city attorney. However, the previous contract retained in place through 6/30/24 to provide support if required. A question received yesterday regarding the $500,000 in carry forward for projects to be determined. Why were these funds not used for current services, thus saving $500,000 from the general fund? In short, previously, Lion Martin was a program and clinic operated by Health Right 360 in a previous contract last approved by the Health Commission on July the 6th, 2021. DPH did not fund HR 360 for the Lion Martin Healthcare Program. Sometime at the onset of COVID, however, HR 360 was going to close the clinic because they were not generating nearly enough revenue to cover their expenses as a clinic. DPH set up a separate contract with HR 360 that hired staff to do mobile medical care during COVID through Lion Martin. Then the BOS, then the Board of Supervisors added back funding to do clinic repairs to Lion Martin and support the infrastructure for them to become its own standalone 501c3 and spin off from HR 360. DPH contract with HR 360 to assist Lion Martin was not for services so much, but for the infrastructure support, which led to the provision of services. That is the source of the $500,000 carry forward that was originally part of this. The funding for the BOS was for the funding of the BOS, or Board of Supervisors add back, was for infrastructure support. Earlier in this process, when the funding notice was sent and the contract documents were being prepared, there were plans to roll forward $500,000 from the 22-23 add back, which was believed to be unspent funding and available for continuing similar infrastructure related needs by Lion Martin. I just received an email recently from the budget manager for primary care, elaborating that these funds are no longer available and will actually not be added to the first year of funding for this contract after all. So that was just found out late yesterday. If you have any questions, programmatic questions, or anything else that you would like to ask, we have Dr. Blake Gregory, the primary care director of population health and quality medical director, and the quality medical director of complex care programs, who's available to respond. And I believe
before we begin, would you clarify that last statement? The 500,000 is no longer available, so it's not part of this contract?
Yeah, so it is not required to be part of the contract, but it was received late after all your documents had sent in. We can resend and remove the 500,000 from the total amount if you would care to do so.
Okay, so as a carryover, it was not part of this part of the contract.
It is found to be not available after all, as was originally believed
All
by the.
But the proposed amount remains the same.
Proposed amount can remain the same.
Commissioner?
So Lion Martin, it's an FQHC?
Yes. I don't know if they're an FQHC. They're a 501c3. I don't think they're an FQHC yet.
Is there, just sort of wondering if there's anything the department has done or can do around achieving FQHC status, or is it just ineligible based on, all of the qualifications? So that might help stabilize funding and such for such a needed service.
That's a great question.
Dr. Gregory.
Respond to that question.
Hello, commissioners. I'm sorry, I don't know the answer to the question about FQHC, but that's something that we can ask.
Sure, and then just send it to me, please, Dr. Gregory. And commissioners, just to remind you really quickly, Lion Martin used to be part of the Clinic Consortium. And so they had their FHQAC, I'm sorry, I didn't say that right, but
FQHC.
yeah, they had that status through the consortium. And then Health Right 360 took it over under their umbrella. And so they're back on their own just to track it. I know I'm speaking for Commissioner Trung, who would say this is one of those things that sometimes doesn't seem logical because within a short period of time, it switches administration and it shifts all these things, but we'll find the answer to your question.
Yeah, that's why I was wondering, because I do remember when Health Right decided they weren't going to continue, and then the Board of Supervisors sort of came to the rescue, but I do wonder about its continued FQHC eligibility or status.
We will get back to you, that info. Thank you, Dr. Gregory.
Well, as a matter of fact, talking about FQHC, what is the status of our own primary care clinics? Is it still for FQHC through the coalition?
Oh. Dr. Gregory, can you answer that one?
And the question was whether the San
Whether
Francisco.
we have our own FQHC or it's actually through the, health consortium.
Yeah, it looks like Beth Neary has a response to that.
Okay, because we've been talking about that and whether to have our own license rather than just being tied. So, okay, that's what just brought that question back up, because the last I knew, we didn't have our own.
Yeah, I think Beth was.
Oh, I might be able to answer that, and if I'm audible now.
Yes, you are. Congratulations.
Okay, great. So the San Francisco Department of Public Health, our primary care locations, including a couple on the hospital campus, are FQHC status, full regular FQHC status, but we don't have a direct relationship with HRSA, the Health Resources and Services Administration Board. It's also through the San Francisco Community Clinic Consortium, not because we're member clinics, because of course we're not member clinics of their non-profit consortium, but we are members of their Healthcare for the Homeless grant program as a subrecipient and have been since the 1980s. We applied jointly with San Francisco Community Clinic Consortium as the lead, and we are we're more than half of the performing sites and about half of the performing services for people experiencing homelessness.
Okay, so we're still not on our own, but within the coalition. Okay.
Right.
Thank you.
Thank you. And so commissioners, I believe that ends the contract report. Please consider a motion to recommend that the full commission approve the report.
So moved.
Oh, I
There's
apologize.
only 7.
I-
I thought we had 9.
I completely apologize.
CSF embrace.
I didn't turn the page to see the last.
There's a UCSF Embrace contract at the end,
Okay.
and I'll make it quick.
It was just my mistake. I apologize.
No worries, no worries. It's approval of an amendment with the contract with UCSF Embrace. Total contract amount not to exceed with contingency of $9,615,203. Remains and will not change. The term of March 1, 2024 through 6/30/2029 is being amended to a new term to now begin on November 1st, 2023, but still ending on June 30th of 2029 for a new total term of 5 years and 8 months, extending or pre-extending the start date by 4 months. The annual amount without contingency will remain the same at $1,327,220. This contract was previously approved at the April 2nd meeting of the Health Commission. The funding notification for this contract had a contract start date of November 1st, 2023. However, contract documents from the vendor were received in mid-January of 2024. With that and our awareness of retroactive start date compliance issues, a start date of 3/1/2024 was discussed and agreed upon by contracting and system of care staff. The contract details were then prepared in March to be brought to the Health Commission meeting in April of last month for review and approval then. Soon after that, the system of care management team learned of and confirmed the need for the start date to actually remain November 1st of 2023 due to program startup cost incurred by the vendor. The contract was at this point still in the early stages of the certification process and was pulled to initiate the change of the start date to begin on November 1st, 2023 to be retroactive in order for the program to be able to capture the startup expenses. For this reason, we are bringing this contract back to note the change in the start date to November 1st. If you have any questions, we have Jessica Brown, the Director of the Office of Justice, Equity, Diversity, and Inclusion, and MHSA, who's available to respond.
And actually, Ms. Brown had to leave the meeting and she's going to be participating remotely because she's presenting another contract. So she might be en route. If we could note the questions, then we can maybe ask them when she gets back on. She just stopped before she left.
My question was, it says here the contract documents were received in mid-January from the vendor, mid-January 2024 from the vendor. So is there a reason that you can share why they were late? It's unlike the previous one where it was the city attorney that did it late. Was this did not involve delays from the city attorney's office, right?
I'm not sure what were the reasons for the delay other than that they were late in being received by the contracts analyst. It may have been that they came in and needed to be sent back for revisions or changes, and it just added to the amount of time. But the contract documents were late in being received. And with that, we initially thought, with it being a new contract and a new program, that it would have a start date of March 1st instead of November 1st, and then found later.
Right. So I get that. And I don't have any problems with being able to backdate in order to capture the expenses. I'm just wondering what led to the delay to begin with, and that would be helpful to know.
We'll try to find that out.
From an administrative standpoint, yeah.
And Ms. Brown, are you on the
Can
phone?
you all
Is that
hear
you?
me?
Oh, yes.
Yes, it is. Sorry. Hi. Thank you so much, commissioners. Thank you. I'm on my way to talk about Proposition 1. So I'm double booked. So my apologies for not being there or not staying in person. But just to answer your question really quickly about the contract documentation, because some of our contractors with the Birthing People contract, they are new. There were some technical assistance that they needed to be able to submit the documents on time. And so there was a bit of a back and forth of just revisions that the contractors had to do during this time, which is also kind of the reason why there was a little bit of delay.
Great. Thank you very much.
I have no questions in that. So I guess now we're prepared to recommend to the full commission.
I move recommendation of approval.
And I would second.
All those in favor?
Aye.
All right, thank you, Mr. Goodwin, and again, thank you for all your service for the city and everyone else who participated today. We can move on to item 4, a request for approval of a new grant agreement with Homeless Children's Network to perform capacity development services. And Ms. Brown, are you able to introduce this?
Yes, I can. So this is just this Homeless Children's Network contract is a part of a larger contract to provide mental health services for birthing people throughout San Francisco. We originally introduced this contract to you all a few months ago. This is one of HCN, Homeless Children's Network, is one of the recipients. They will also be in partnership with Rams Rafiki and UCSF to provide culturally responsive mental health services for birthing people throughout San Francisco. And so we wanted to go ahead and introduce this part of the contractor with the Homeless Children's Network. I'm so sorry. And to provide information for the commissioners as well on the contract.
Any questions, commissioners?
Just reading the answers.
Right.
I've questioned whether or not we should go out to 3 years, and the response actually speaks about 2 years post-birth. So I'm not quite sure why then we chose 3 years post-birth for adding to the number of people who can use it. I mean, that can be, a client here.
Yeah, and that speaks to the diversity of the CBOs that we've chosen for this work. We wanted to be able to have a range of postpartum services between 1 to 3 years maximum. Some of our contractors may have decided to select, providing postpartum up to 2. Again, just because of the diversity of the clients that they're serving in their network. But as I mentioned before, these 4 CBOs will be working together. So it also has to do with looking at the graduation of services, right? So under the Mental Health Services Act, we focus on full partnerships, and the goal of that is to also have some more step-down services. So not only having the intensive case management part of it, but also graduating clients more into outpatient. So as we're thinking about birthing people and postpartum, we want to be able to provide a variety of different levels of services, whether that be the higher level threshold where they can connect to our system, or let's say a parent, particularly a birthing person that is having services with HCN, maybe they may graduate out of that services early, or they may find themselves needing more services after they have got down to the outpatient. And so this is where the other CBOs will be able to step in. But the goal was to have that range so that we can capture capture and support clients with the most need.
Okay, well, of course, you were all doing the solicitation, so I don't want to change that. I'm just sort of pointing out that if we were trying to add more people available for the same amount of money, we could cut down the extension of the period of time people could join the program, especially since seems to me the critical periods are the prenatal and the delivery period and the immediate postpartum. But leave that to you all to figure out.
So I did have a question. Since you said there's a diversity of, I guess, existing capacity within the 4 organizations that are part of this partnership. So does that mean that if, or would all 4 need the same amount of support, funding support to develop different capacities over the course of the contract? Or if, say, one of the organizations uh, reaches the limits of the capacity that they need to be formed, could the funding then be shared with the others that haven't? Just wondering how flexible that is in terms of the capacity building, given that you said that there are differing needs within, or differing, or there's a diversity within these organizations, and that's totally understandable.
Yeah.
We wouldn't expect them to be uniform. So just wondering how flexible that funding is.
Yeah, thank you so much, Commissioner. The flexibility of the funding is contingent on some of the state changes with Proposition 1. We stand by, as long as the funding is available, we're able to, add into the contract if our contractors are seeing that they're providing more services or needed to alter it. However, given the volatility of our funding, we're unable to guarantee any additional support until we're able to look at our cash flow. So typically with the Mental Health Services Act, we depend heavily on that taxpayers, those that make over $1 million, we take a 1% tax income from them. And so we have to wait until probably most likely around April, no later than July, to see what our cash flow is. So their base amount will stay the same. But if there are some additional, costs because of, as you mentioned, the diversity of clients that are being served, we'll have to revisit it based off of our budget.
Okay, I think I was speaking more to the funds within the existing arrangement and how there can be flexibility within that amongst the different partners. But just giving the current capacity and the hoped for future capacity development. But I understand that the overall, I understand the overall limitations. Yeah.
Okay, were you mentioning, like, let's say one of the CBOs tend to provide more services than the other? Can we change the funding allocation?
Well, given that this is supposed to, the contract is to build capacity, that, again, I'm assuming that there's not uniform capacity building ability within each of the organizations. And so some might, have more capacity than others. And so they might need the funding in a different way or might not need the funding. And then within, again, the network that can be shared. I mean, it's I didn't mean to belabor this, but it was just it's a question about flexibility within the current contract amongst the network partners.
Yeah, we wanted to make it equal. We wanted, just given some of the community feedback as far as making sure that we had a bunch of different CBOs that we can work with, like UCSF and HCN, technically being a new one. And so, just one second, sorry. We want to be flexible, of course, but in the sense that if a CBO is experiencing really more capacity building, that we would just try to add funding from MHSA. The other thing about this is, too, the partnership among the CBOs. So if there were, maybe, as to your point, UCSF, they have built this type of program before. Their Embrace program has been around for a while. So they're going to be most likely helping with the capacity building of the other programs and providing best practices. But we did not tie that to their funding allocation. We just tied that to our expectation as DPH to have them work with each other for capacity building and support as they're launching. And things could change eventually, but our goal would be to continue to have the funding equally split. And if there are additional costs that maybe one of the CBOs is acquiring over the others, to just think about how to maybe add, if funding is available, to their contract to keep things as equal as possible.
Right. So this is really a baseline then, baseline funding. Yeah. Okay. Thank you.
Yeah.
I think Commissioner Gerardo had a question as to how many people would be served, and yet this is a professional capacity building contract. So I'm sort of now torn between the two. One, are we building the capacity, and therefore the capacity is only limited to 70, or is that sort of an estimate as to what the four agencies are going to be reaching out to do, but that the program is actually to train people?
Well, the program is a mixture of both. So it would be to train behavioral health clinicians in postpartum behavioral health interventions. However, we'll also be able to serve families. So each of the CBOs have a certain estimate of what they envision of serving. So for HCN, they have about 70 people per year that they plan to serve with this contract, right? And Rams had, I believe it might have been about 50 to possibly 100, and that was the same thing with UCSF. So they're each going to have their own estimate of clients that will serve based off of, what their services are providing, their location, and also, again, their capacity building amongst the clinicians that they're going to be training, and also their partnership with each other.
So you're speaking about UCSF specifically as one agency. Is the number 70, just to clarify for Dr. Gerardo, per agency, or what you're expecting we're going to be, the client, the total client base for per year?
The number is going to be contingent on the agency. They each have their own amount that they've estimated. This 70 is for HCN. So we are hoping altogether each contractor can serve between 50 to 100 people per year. And that's going to be for each of the contracts, right? And that includes community events, capacity building, and also one-to-one services and group sessions. So each of them will have listed out their capacity based off of their framework and what their services will offer. So we're expecting around that range for each of these contracts.
So it would be a range per agency?
Yes. Yeah.
Yes, thank you, because I think that helps clarify, because 70 sounds like a small number per year. Thank you. So it's 70 per agency average. Okay, thank you. Commissioners, was there public testimony on this?
No, yes, everyone here is, well, actually,
Okay,
until we get general public comment, there's no public comment on these items.
okay. Commissioner questions, or are we prepared to recommend this contract?
Yes.
Yes.
Yeah, so I move that we recommend approval.
A second?
All those in favor?
Aye.
All right, thank you, and thanks, Ms. Brown. Item
Thank you
5
all.
is
Thank you, Commissioner.
item 5 is request for approval of a new contract with Laboratory Corporation of America.
Good afternoon. My name is Teresa Marinan. I'm the Director of Pharmacy for BHS. I'm here to request approval for Laboratory of America contract. The term for this contract is from May 22, 2024 till December 31st, 2026. I want to clarify that the amount spending was corrected after I submitted the response yesterday. So the annual estimated spending was changed to $205,829. The overall amount for the contract duration is $614,741. Our target population are mental health clients within the BHS system of care. LabCorp provides laboratory testing services to process a huge variety of lab testings, lab samples. They have multiple laboratory testing sites throughout San Francisco that are accessible and convenient to our mental health clients. LabCorp uniquely supports our mental health clients by accepting lab specimens obtained in our mental health clinics, or more significantly, clients can also go to a location near them. The option is paramount for this highly vulnerable population. LabCorp is a Vizient vendor that allows DPH access to lower processing costs of lab tests. Our DPH-run public health lab confirmed that they are not able to offer phlebotomy services to our clients and doesn't have multiple locations. This is the critical service that necessitates the need for the third-party vendor. With BHS moving into Epic and requirements of lab to be ordered in Epic, it requires a standalone contract to allow for a bidirectional interface of lab orders in Epic. So this interface makes the experience seamless for both providers and clients since the lab results become available in real time.
Commissioner?
Sorry, so is this the first time that we're going to be contracting out for these types of services?
Actually, I'm sorry, I missed it. So BHS, we've been working with LabCorp for more than 10 years now as a subcontractor through our pharmacy benefit manager. So we've been using LabCorp, which just didn't have a contract.
For this type of population as well?
Yes.
Okay, so it's proven contract, okay.
Yes.
I have no further questions. So we're prepared to recommend,
Yes, move recommendation of approval.
and I would second that.
All those in favor?
Aye.
All right, thank you so much.
Thank you, Commissioners.
And thanks for waiting. I know it's difficult, or it's difficult for all you to wait, but we appreciate it. And you're welcome to leave once you present. Item 6 is a request for approval of a new professional services agreement with United Audit Systems Incorporated.
Hi, good afternoon. My name is Tammy Higgison. I'm from the Health Information Services Department. I'm the Assistant Director, here to speak on this contract. This contract is with Vizient vendor United Audit Systems. We need to utilize this contract to provide cancer registry services to San Francisco General Hospital. Currently, we are pending hiring an internal person. The person we had before did retire, which left us with limited options. Due to the requirement in the state of California for this person to have a certified tumor registrar certification. So this contract will only be used in lieu of that permanent hire.
No question.
So hospitals are used to having cancer centers, I mean registries. So why are we going outside in order to do the work?
Great question. So currently we utilize the HR classification 2112, which is a medical record technician. That classification is kind of a conglomerate of things that would occur, or duties rather, that would occur in the Health Information Services Department. It does not by default require what's called a CTR certification, that cancer tumor registration certification. Therefore, in order to hire for this particular need for the state of California, we use that classification and then we post it with a special condition. So HR processes do have a prolonged turnaround time normally. That special condition makes it that much longer because we do have to seek out those candidates with that certification. And again, our previous person had retired very suddenly, which left us with limited options. Currently, we're covering everything with a part-time person, but that person's having to do extra hours. And in the event that person is unable to work, we are unable to process those cancer registries.
So that's reading this is a 1-year contract and we're still trying to fill our position.
Yes, sir.
Okay, thank you. I have no further questions.
So I recommend, move to recommend approval.
And I would second that.
All those in favor?
Aye.
All right, thank you.
Thank you.
Thank you.
Item 7 is request for approval of a new contract with UCSF.
Good afternoon, Commissioners. My name is Eduardo Sida, Director of Administration, Policy, and Performance for the Population Health Division. Here to present on the UCSF contract as needed clinical consultation services. And I also have on WebEx, Dr. Catherine Brooks and Dr. Justin from UCSF to help answer support any questions. This contract would serve as an extension of the long-standing partnership between the Department of Public Health and UCSF. Our collaborative relationship with UCSF has yielded numerous successful public health initiatives encompassing efforts from HIV/AIDS to our current work on overdose prevention. This relationship helps us ensure we are offering the latest approved approaches, as well as exploring new frontiers in the field of community engagement, research, and health equity. The requested clinical consultation services from the UC providers would include 4 main areas under this contract. The first one is to review and develop recommendations aligned with the California Department of Public Health and national guidelines for emerging health concerns. The second is to facilitate clinical policy meetings to gather input from internal and external providers on health concerns, such as we've done for the COVID, Mpox, and overdose responses. The third is to collaborate with the county health officer to draft communication language for various platforms such as the health orders. And then lastly, to address requests from other sections for clinical consultation on patient and provider communications. So some examples that we've done in the past were the COVID vaccine ask a doctor sessions at vaccination sites, the facilitation of community town hall meetings for providers and the public, and interpreting local, state, and federal policies or directives as was done for the COVID and Mpox emergency declarations. That's pretty much it. If you have any questions.
So you said that the department has had this type of consultative
Yes.
relationship before under a different contract, or?
Correct.
So this is a new contract for the same type of services?
Yeah, yes, because the previous contracts were more involving of more services, especially during COVID. And so we're trying to just narrow down the specific services needed moving forward.
Okay, so it's a limited scope?
Yeah, correct.
Okay, great. And who, so Dr. Phillip is the one that's going to determine how and when?
Yeah, Dr. Susan Phillip and her deputy health officers would determine whether we could do it in-house with our specialties or we need to contract out with our UCSF partners.
Okay.
Yeah.
Thank you.
Right, they had already answered my question, so we can proceed with the recommendation.
Move to recommend approval.
And I would second.
All those in favor?
Aye.
All right, thank you very much. All right, we can move on to emerging issues.
Do we have any emerging issues at this point? I mean, there are a lot of pending issues, I guess.
Yeah, so I don't want to bring any more.
We're not adding any today.
Okay, great. And then the next item is public comment. Do we have any public comment in the room? All right, I'm not hearing any public comment, so we can move on to consideration for adjournment.
Move
Motion for adjournment.
Move to adjourn.
All those in favor?
Aye.
All right, thank you, everyone.
Thank
Have a good day. And
Good luck, team.
Thank you very much.